Well, thank you to the association for inviting us to talk to you this afternoon about clinical trials in the UK in search of a cure. My name is David Buchanan. I work with Professor Hillmen here in Leeds and have done for a long time now. And he said something earlier on that I think I told him what to do. Well, that couldn't be further from the truth. So I'm going to kick off this quartet from Jimmy's with just a basic overview of what clinical trials are. Some of you probably have a fairly good understanding of what clinical trials are. There might be some who it's a fairly new idea to. So I'll try and describe it somewhere in the middle. So this is it's an unusual slide. It's not unusual because it's a graph. It's unusual because in a presentation about clinical trials, it's the only slide that has a graph on it. Normally, on a presentation like this, you probably have at least 30 slides with a graph. But clearly, in Leeds, we're trying to get away from slides, and I'll try and get away from complicated graphs, but this is a fairly straightforward one. But it's interesting, even though it's rather old, in what it tells us about things that are going on in the background behind these lines and curves. If you look at the top slide, top graph, this illustrates children diagnosed with acute lymphocytic or lymphoblastic leukemia between the ages of 0 and 14. And the lines you see are 5-year plots of over a period of time, starting in the early 70s, going right through to the late 90s. So if you look at the red line to begin with, this is 1971 to 1975, and it illustrates the survival of patients diagnosed during that period of time. So I haven't got a pointer, so I'll use my finger. So this is at point diagnosis. And if we look at 5 years after diagnosis, we see that most patients have unfortunately died at that point. So there's only about 30% of patients still alive, which is a fairly bleak diagnosis and prognosis to get. If we go up to the next line up, that's the next 5 years. So if you're diagnosed between 1976 and 1980, then there's quite an increase in your chances of survival, just above 50%. And then you get incremental rises on those plots thereafter. I think today, or the most recent published statistics are around about 82% survival. So there's a turnaround really in diagnosis and prognosis for these patients, from 30% survival after 5 years to about 82%. So of course you have to ask the question, what was going on during that period of time? And there'll be lots of factors involved. There'll be better diagnostics, better supportive care for these patients, better treatments. But it's interesting to note that back in 1971, there was in the UK a consistent effort to enter patients within this group into clinical trials. So can I just get some water? I'm drying up here. Aye. That's great, thank you. Oh, that's better, thank you. So there was an effort within the UK to establish trials within all the major centres where where these patients would be diagnosed and later treated. And these were big trials with an emphasis on randomised controlled trials. So if you were diagnosed from 1971, that child would be offered participation in a trial. It was organised on a national basis, and one trial's results would inform the next trial, and so on and so forth. So, what do we mean by clinical trials? Well, it's Sport Relief Day today, in fact all this week, so I thought I would try and make an analogy with cycling, a bit of sport. So this is a chain ring. If you're into cycling, I'm a keen cyclist, so I assume everybody else is interested in cycling, so I apologise if you're not. This is what we call a chain ring. It's the main drive of your bicycle. Bradley Wiggins, quite a long time ago, felt that he could improve his performance by using what's called an elliptical chain ring. Chain rings are normally perfectly circular. If you look on this slide, you've got a slightly sort of flattened edge on both sides, and forming a sort of an ellipse. And there's a good theory behind this, because we know that there's a dead space in the cycling, or the pedalling action, when the crank arms are totally vertical. Having an ellipse gets rid of that. So in theory, this should improve performance. So how do we go about testing this out? First thing we want to do is to make sure that the intervention is safe, and secondly, that it works. Now, we don't know whether it's safe or not. There's just theory at this point. So the first place to start would be in the laboratory, on the bench, and you can test this out through stress methods, etc., etc. If that seems to justify your theory, then you can move into trying it on a small number of cyclists. We don't really know whether it's safe or not, so you want to expose a minimal number of cyclists to the new chain ring. The main focus of this is to make sure that the whole thing is safe. So you'll be monitoring the safety very closely. You don't really want to know whether it's working at this point. You just want to know whether the new chain ring is going to be safe and not break Bradley Wiggins' collarbone as it did in the Tour de France a number of years ago. If all of that suggests that yes, the new chain ring is safe, then you want to test it out on some more cyclists. And the emphasis will change at this point from safety to whether the thing's working, providing an improved performance. But of course, always in the background, keeping a careful eye on whether the thing is actually safe. Unlike this, if it is shown to be safe, then you'd want to take this on to the next stage, which is testing it out on more people, more cyclists. So the first thing to do is try and control your testing. So you would want two identical bikes, but the only difference here is you've got one with an elliptical chainring and you've got one with a traditional chainring. You then need to look at your population of cyclists. Of course, cyclists come in all different shapes and forms. You've got mature males in lycra. You've got Laura Trott or Laura Kenny, who's a whip of a girl who wins gold medals on the track. So there's a great variance within that population. It'll be impossible to test all cyclists, so you need to draw a sample from the cycling population big enough to try and dilute down all of those variances, like tall, fat, thin, male, female, etc., etc. Once you've done that and you've got your sample, you split them into two groups. This is the randomized part of the trial. So this is an unusual photo which shows Australia overhauling the Great Britain team pursuit, which is most unusual, but an unfortunate fact then. That was in Hong Kong. So really what we've just described here is the sort of scientific basis, at least this endpoint, the scientific basis to a randomized controlled trial. We've got our population of cyclists, which is massive. We need to draw a sample from that, which is manageable, but needs to be big enough statistically to water down all the variances within that overall population. We then test it out with the trial. We've got two groups. We've got a control arm, which is a circular chain ring, and then you've got your elliptical chain ring here. You look at the results, your findings, and then you apply your findings back to this total population here. There are two things to consider here for this to work properly. The first thing is that you need to be controlling your trial or your experiment, for want of a better word, at this point. And that's controlling variables, really, narrowing things down as best you can. For example, if you're testing your control group in a nice, calm summer's day, for most of them, but the most of the people or cyclists on this group are on a windy winter day, then you can't really rely on your results from that to apply back to here, because there are things getting involved within that process of the experiment which are going to interfere with the results, going to skew the results. The other important thing is that this bit here, your sample population, needs to truly reflect your general population. Otherwise, if you apply your results, it can have some disastrous consequences, particularly in medicine. The cycling analogy, to follow it a little bit further, if you had a predominantly time trialist sort of cyclist within this population, and you excluded all your climbers who love hills, then to apply your results back to a general population is not going to work. Interestingly, with cancer trials, it's less so now, it's a recognized issue, but cancer trials were sometimes felt that the sponsors selected a younger, fitter group out for particular agents, and we know that cancer generally is a disease of the middle-aged and older person. So if you select out a particularly fit group that doesn't really reflect the older population within the general population, then you can have fairly disastrous consequences if you're going to apply, say that the chemotherapy tested here applies to your general population, which is in fact a lot older than your sample population. So it's an important factor. So that's really internal validity and the external validity of the trial. So if we try and get away from cycling now, and we replace our elliptical chain ring with a trial drug, this is venetoclax, and we swap Bradley Wiggins for a patient. This is Andy Wright, a patient of ours, who you might have heard on the radio, interviewed by Simon Cox. Andy is the chap in the tank top, by the way. Then we can see the process that sort of comes out, and this is a stepwise process that can be identified into sort of set phases that trial development and pharmaceutical development needs to go through. So we start off with studies in the lab, not involving human beings at all, might involve cells or cell lines. That would then move into animal studies. Once these things are giving evidence to the theories behind them, and it seemed to be safe in maybe animal models, then we move into early phase trials. These we probably class as just phase 1 together. We tend to deal with sort of phase 1, phase 2 and phase 3 trials. So phase 1 trials are really the first studies in human beings. They involve very small numbers of people. You need to establish that the drug or the intervention is safe before you move anywhere. If they're successful, then they move into phase 2 studies where the focus moves in your objectives to more efficacy rather than safety, although safety is still paramount and could stop a trial at any point. Once that is seen to be successful, then you move into your really big studies, which are normally international studies, statistically needing large numbers of patients. These are normally randomized controlled trials and require a lot of patients and a lot of money. So they're very expensive, big trials. So a few examples of those. This dates back about 10 years or so, but we did a phase 1 study here in Leeds. It was an international study looking at a drug called lenalidomide. It's a drug which already had a license in another B-cell malignancy called multiple myeloma. So the objectives of this study were primarily to do with safety and taking the drug through a very careful stepwise increase in doses until you reached your maximum tolerated dose. Of course, secondary objectives, we're dealing with patients, of course, during all of this time, and there was already some strong theoretical evidence that this is going to work in CLL. So we're also looking at efficacy endpoints as well. And did you see there are only 50 patients sort of within this study. This is just a basic schema on what a phase 1 study would be, and it does vary between studies, but this is a very simple, straightforward way to explain it. You'd have a starting dose which would be a very low dose and often established on animal modeling. You would only treat maybe 3 patients. In the lenalidomide case, it was actually more, but so you could be treating just 3 patients, and that's at an international level. So you, as a site, it can become quite problematic because you're having to reserve slots for those patients to come onto an early phase study. So there's a lot of starting and then stopping due to toxicities and cohorts getting full up. You're looking at adverse events or side effects. So you literally count those adverse events. Now, we don't count those, we report them, but they're counted by the sponsor and a data monitoring committee who would sit, and these are independent experts who sort of check that the trial is running safely, look at the up-to-date data, and make the decision on whether the trial is going to stop or whether it's going to go ahead. If there are no adverse events of any significance, then you would increase the dose and recruit 3 more patients, and then the cycle carries on. If you're getting some toxicity, maybe 1 significant adverse event, then you might want to treat another 3 patients and assess those events as well. If you're getting significant toxicity, i.e. 2 or more, then that's where the trial stops and you go back a dose. So it's a very stop-start process, and particularly difficult for patients who might be waiting for a phase 1 trial. And yeah, well, it sort of speaks for itself. So this is the schema really from the lenalidomide sort of dose escalation. It is a bit different to what I've just showed you, but it follows the same sort of principle. You had a ramp-up dose, a very small dose of 2.5 milligrams going to 5, and then they were looking at 6 patients within a 10 milligram dosing level, not going beyond that. And over 2 cycles, they were assessing those adverse events. If it was seen to be okay to go up to the next dose level, then you would open the cohort up to another new 6 patients and go up to 15 milligrams, going through that dose escalation again. So very drawn out, but crucially, this is the way that you need to treat safety aspects of new drugs. You don't know what you're going to be expecting a lot of the time. This is a phase 2 study, the Clarity study, which is being run from here. The sponsor's actually in Birmingham, but it's within the UK. And it's looking at, as you probably know, venetoclax and ibrutinib. So the 50 patients again. Now, this is a phase 2 trial, still looking at the same number of patients as the phase 1, but you have to remember that the phase 1 study was only really treating 3 patients at a time, and that could have stopped at any point in time. This is looking at 50 patients total recruitment. There was still some anxiety, I suppose, about the combining the 2 drugs. So a lot of energy was spent monitoring the adverse events during that sort of combination stage. Particularly, well, the ramp-in was with the venetoclax was obviously the concern. But you notice the primary endpoint is actually sort of efficacy. So Peter spoke about MRD earlier on, and the primary endpoint sort of is focused on that. Toxicity as secondary sort of objective. But of course, if toxicity became a problem, then that could stop the trial at any point. And the last trial, which is a phase 3 trial, which is being run internationally, again, big trial, but we have it open here in Leeds and has been for a couple of years now. And that's looking at acalabrutinib, and it's being randomized against ibrutinib. So it's a straight comparison with ibrutinib. So the objectives here are slightly different in that they're trying to establish efficacy and whether the drug is better or worse than ibrutinib. There are secondary endpoints, of course, to do with risk. One of the things that this drug is they're hoping to see is that it has a better side effect profile than ibrutinib. So that's clearly an important objective. And that's just the schema of the trial itself. So it's a straightforward randomization. Half patients would have ibrutinib and half the patients would have ACP-196, which is acalabrutinib. So quickly to summarize then, clinical trials, they offer a systematic stepwise approach to clinical development. They expose patients at minimal amount of risk as possible. It's a very long process, but risk is clearly the main concern. They are committing to patients, and patients who have participated in a trial, and of course trials do differ, they will always have more visits to hospital. There are uncertainty issues around the trial, which leads on to our last bit, which we have to always remember that, you know, clinical trials are part of, maybe for want of a better word, research projects. So, you know, that means that there is some uncertainty about the drug's efficacy, its side effects, and there's a reason for the trial protocol being there in the first place. So it's trying to answer questions. And I'll hand you over to Professor Hillmen, who will talk a bit more in depth.